Very good. Thank you. Minister, thank you. Mary Louise. Excellent. Well, it's a great pleasure to welcome honourable members and senators, invited guests and Pathology Technology Australia members to our first ever Innovation Day in Parliament House, Canberra. My name is Dean Whiting. I'm the CEO of Pathology Technology Australia. But before I begin, please let me make the following acknowledgement. In the spirit of reconciliation, Pathology Technology Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Pathology Technology Australia is the peak body representing the companies that are essentially the R&D division of pathology in Australia. They are the manufacturers, the suppliers, the supporters of the tests and technology that make pathology possible. A very good example of this is what our members contributed to healthcare in Australia during the COVID-19 pandemic, where within 6 weeks of the COVID RNA being sequenced, the first commercial kits to detect the virus were developed by our members, both locally and globally. Within 3 months, manufacturing had ramped up to the extent where millions of tests were being produced every week to satisfy a growing global demand. Our members depend heavily on air freight space to import a broad range of tests that Australians depend upon for their healthcare. And as you know, air freight space all but disappeared during the first months of the pandemic. And our members went to extraordinary lengths to ensure that Australians did not let Australians down in the vital testing that they needed. And our organisation our members and our organisation stands prepared to do it all again if that becomes necessary. But given the opportunity, our members could actually do a lot more for the future of Australia. We have some of the best research organisations in Australia delivering some of the world's best innovations in medical technology and pathology. And with the right policy and funding settings in Australia, we could become a global leader in manufacturing and supply of technology and tests for point of care, for genomics, for molecular and for digital pathology. This would grow employment, it would grow export opportunities, and importantly, could serve to attract even more clinical research organisations into Australia, potentially tapping into the lucrative global clinical trials area. Not to mention the contribution that this would make to our supply chain resilience. And you can learn more about these things here today because we've set up a number of information stations which are available, one for point of care testing, one for genomics, one which we call the people behind the people, which looks at some very nice innovations that we have for helping training pathologists, training laboratory staff and supporting the technology in the field wherever it is. We have a station set up looking at what innovation we have in Australia already and the health economics behind it. And then for the brave-hearted amongst you, Diabetes New South Wales and ACT have set up a station where you can have a hemoglobin A1C test, as the Minister has just had, a test which in a few minutes with a single finger prick of blood will give a laboratory quality result in just minutes. And just some of the things that we're able to do. In a moment, I'll introduce a wonderful 3 panel speakers for today. But before I do that, it is my absolute privilege to invite the Honorary Greg Hunt, Minister for Health, to open our innovation today and to open this lunchtime session. So thank you very much, Minister.
Thanks very much to Dean and to David and to John from Pathology Technology Australia, to Mary Louise for all of your work through the course of the pandemic, and equally to John Skerritt and the TGA. I mean, what a team Australia has had. And I want to thank everybody. And, subject to today's figures, today is likely to be the 52nd day in 2021 with 0 cases of community transmission, over 62% of days this year. And we would not have got there. We would not have got there without the contribution of the pathology sector. The ability for rapid testing and turnaround in the most pressured global environment was impossible to achieve. And yet we did it here in Australia, and you did it, and the members did it, and everybody involved. So I want to thank all of you for that. Now, literally seconds before I got up, I received the result of my HPA 1C test, and I'm delighted to be able to say it measures 5.3 on the scale. So I think everything's normal. So let me stand back for a second and to think of the sector, COVID, and the future. If you think of the sector, 50 members, over 50 members, over 2,600 employees, 50 million in R&D investment a year, 500 million tests that you do. Well, actually, that's not quite true. After my recent visit to hospital in New South Wales, 501 million tests, given the number, I feel as if I'm the national pincushion, emphasised again today. But honestly, when you see the way that pathology testing can provide the guide and therefore the pathway to treatment, you see what modern medicine is about. And that's what you've been doing. And I want to thank all of you for that. The second thing, of course, is through the pandemic, it was impossible that we could have supplied Australia with the tests. There was a global challenge in terms of supply and demand, the likes of which we have never seen before. And we lived and breathed it. Like Kylie in my office here was, along with the department and John, supply chain manager for the nation. And we were working on bringing supplies in, on working quietly, on working with our Australian producers, on working with the sector for the international suppliers. And what's fascinating is that the London School of Hygiene and Tropical Medicine, when they did the early analyses, determined that Australia had the most accurate testing regime in the world. And they did a regression analysis, and that was their conclusion. And that only came about because we maintained a focus on quality, and at the same time we were able to, with your help, maintain that supply. That saved lives. That was one of the 4 pillars of Australia's containment response: borders, testing, tracing, distancing. Those 4 things all came together. At the same time, we were able to develop the support for the pathology sector with the pathology viability guarantee that we put in place. And that meant whilst COVID tests were up, and I think it's 12 million from yourselves, over 15 million nationwide, other tests were down, and there were real threats to the sector, but we maintained that sector through the course of the pandemic whilst you served and protected the nation. And there's no discontinuity in service. So that was immensely important. So then that brings me to the future. And when you think about that future, the HbA1c test is an exemplar. So John and his team are all the time assessing new technologies, looking for safety, looking for effectiveness, making sure, as they've just done with the assessment of the CSL plant for manufacturing for the vaccines, and then the batch testing, as they'll do on a progressive and continuous basis, that safety trumps everything. But at the same time, we're working to a faster pace than ever before to bring forward the new product. But at the meta level, the genomics mission is a $500 million 10-year investment, and standard of care in genomic testing is the goal to come out of this, to be a global leader on that front. And as an initial step, I'm really thrilled to be able to announce that the tests that many of you have taken today, Andrew Wilkie and myself and others, the HbA1c test will be made available on Medicare from the 1st of November. Wow. And so and that's part of bringing the future forward to now. And you're the people that have done it. But I want to thank you. Thank John, you and your team. You've been extraordinary. But Mary Louise, you and all of our epidemiological community. I never knew Australia had quite so many epidemiologists. But together, along with the pathology sector, you have all stepped up and stepped in to help save lives and protect lives. So I am delighted to be able to launch Australia's Pathology Technology Australia seminar and series today, and to thank you for all that you've done. I'll have to return to the work of the portfolio and COVID, but it's just an honour, and as I say, to have lifted your number of tests from 500 to 501 million has been a small personal contribution. Thank you very much.
Wow. I was hoping that we would get such an announcement today, but I didn't really expect it. So that's the culmination of 7 years' work from this organisation to get a reimbursement for a point of care test. It's the first such test reimbursed in nearly 25 years. So that's really something. And along with all the other things that are happening in my life at the moment, that's another W. What can you think of, Ellie? Wow. Oh, okay. So we go on to what I think is a really wonderful seminar here today. And while I gather my thoughts, we have three absolutely wonderful speakers. Professor Mary Louise McLaws, epidemiologist, University of New South Wales, and key advisor to the World Health Organization, Dr. John Melke, Managing Director and CEO of Genetic Signatures. But first up, a man who probably needs no introduction, but Adjunct Professor John Skerritt, the Deputy Secretary, Health Products Regulation at the Department of Health. John's going to talk to us a little bit about some of the challenges and how he went about, his team did this magnificent job that we've all been praising this morning, getting tests into the hands of laboratories and for the benefit of all Australians. So, John, please, over to you.
Thanks. Good afternoon, everyone. I'm going to talk a little bit about what we've done during unprecedented times and hopefully some unprecedented responses in regulation and delivery of COVID tests. I mean, regulation is only just a means to an end. It's actually about getting tests, as the Minister said, but are safe and effective into the hands of those who should use them. Because presentations like this end up on websites for general distribution, we put a bit of background and context for people who may not eat and breathe this like everyone in the room does. And look, I'll race through those bits because there's nothing worse than sitting in a seminar having someone read a slide out to you where you already know what it's all about. And I'll focus on some of the specific issues and hopefully give enough time for discussion like this. So people here know what IVDs are, and you know that except for a few exemptions, they've got to go through a TGA approval process. I'll come back to that because some other regulators during COVID adopted some different approaches, and there's been a fair bit of navel gazing, especially from FDA, if you've kept up with some of the editorials and other things in New England Journal of Medicine and so forth, including written by our counterparts at FDA. So I'm not dumping them in it, but that's a cause for some reflection. Again, you don't need a lecture on the different types of COVID tests or even the different types of diagnostic tests. I do believe that we have a long way to go still to see the potential for point of care and self-testing in the community. I say that with some degree of bias. I actually was the lead author of a paper in Lancet in if I say it really quickly, it's not embarrassing. February 1991. Did I say that quickly enough? That's more than 30 years ago. I was only at primary school at the time. So I was actually the lead author of a lead paper most days. I don't know how. I think I mustn't have had much else happening that week of a paper. And I don't tend to go into details because some of these have been commercialised with Fortune 500 companies and so forth, of a point of care, or even actually it was a self-test. We were probably ahead of our time then. We went on, and some of these covered not just the medical area, they went into the food and environmental area, but we did commercialise, I think, about 16 or 18 in a number of countries, rapid tests. And we could do things that, 30 years ago up to, and I got out of that game about 20 years ago, but through the 90s, we could do some remarkable things. Delighted to hear the HB1AC news. And who knows where we'll go in the future with more of those tests. I do think it's an area where the potential has not yet been fulfilled. Often the challenges are not, as you know better than I do, not because of a technology. Often sensitivity and specificity, if I can speak out of turn, as I'm used to doing, tend to be put up as a bit of a smokescreen, I would say. It's now, on the other hand, though, sometimes the performance in expert user hands and for say a do-it-yourself test at home are vastly different. People, especially the 49% of the world who are male, refuse to read instructions. I still haven't read the instructions to my mobile phone, and my spouse has to show me how to use certain features. So we do have an issue there. But in general, I do think if you'd asked me 30 years ago where would be now with self-tests and rapid tests, I would have thought, frankly, they'd be much more widely used. But of course, there's issues such as where it fits into clinical flows, the old thing of reimbursement. And I could say there are obviously sunk costs and also well-established interests working on laboratory-based tests. And so it's a more complex world than that. So what did we do? Now, this slide is focused on urgent access to COVID tests, but I could have gone up a level and said, we did a lot more, and Greg Hunt kindly mentioned it, or at least hinted at it. We did a lot more than just focus on actually the regulatory approval side. During the months of April and May 2020, I had literally stuck with a bit of sticky tape to my study wall, be very limited because they could fit on 2 sheets of paper, flight timetables of who was bringing planes into Sydney. I knew when China Southern was flying into Sydney and Melbourne. And so I don't want to work for Toll or for Austrade or anything, but we were working hand in glove with them to get products in. And we were regularly reminding partners in government, but it wasn't just about Australia getting its lobsters and coal and wheat and God knows what else out. Not that they go on planes, the lobsters do. They fly business, but basically it was actually about getting medicines and tests and devices into the country. So we realised this early on. There was an initial emergency exemption that you're familiar with. It was often misunderstood, the scope of it, and we had to do a lot of communications. It was also misunderstood within state and territory governments and within our own governments. But and again, the absolute remarkable speed in which the first diagnostic tests were developed was just that, after the sequence was known. And from a piece of RNA being sequenced, a virus being sequenced, to actually having regulatory approval. And we're among the first countries in the world to actually give regulatory approval for these tests. And these weren't an emergency use exemption, and FDA, even before they did that, had a sort of send it in, and it's not even an EUA process. And so we actually had teams looking at these things starting from as soon as we got them in late February, early March, and we prioritised them. And how did we manage it? Well, we've got a lot of tired people, but we had dedicated teams. We moved staff around, but the basic line is we had a lot of people working long hours. A lot of it also, especially for some of the rapid lateral flow immunochromatography tests, a lot of the people trying to bring those tests in. I mean, we had building supply companies. We had a paint company who decided it was a nice line of money because a mate knew someone in China. Now, we had everything in between, right through to the established industry. And so we had to spend a lot of time providing support to many of the new users in industry. And we also had to explain a bit about those tests. Now, our job is to mainly, and because there's grey areas, but mainly look at performance of tests and so forth. There are other groups who provide advice on where they fit into testing regimens. And at times there's often tensions in those things. And again, I do think while some of the early tests were perhaps the instructions for use didn't explain, that you're not going to get a seroconversion response in the first 3 days of infection. They tended to conveniently either not know or ignore some of those things. I actually think some of those tests were much maligned, and generally a number of the tests, as far as detecting whether you had infection out at 21 days, were actually quite high in their specificity and sensitivity. People who had the common cold were not giving false positives, but they weren't real useful if you had the virus only 48 hours ago. So we work closely and we spend a lot of time communicating what these things do and don't do within government. We assessed applications really quickly. It was standard approval, but we also recognised that some of the serum panels, either we had to get more information on them, were these patients and individuals who, and often they came from China, some of the early serum panels, were they people who, serum taken in late January or late February from people who had been infected in January in Wuhan, or was it people from 2 or 3 days ago? And often that information was not clear. It was based on available sample. And to be pragmatic, we knew it was hard to get, time series and so forth. So we did build a risk mitigation strategy, post-market conditions, supply to only particular and use individuals and use in certain circumstances. Doherty, who started to get reasonable serum panels, especially time series, the Doherty Institute. And also, as I said, we contributed policy to the national testing strategy, but we didn't drive it. And here's just some data on how many tests of various sorts have been approved. I think we're rapid antigen, we're 16. I keep on saying 15, but it's 16. And a heck of a lot of PCRs and a number of rapid antibody tests and so forth. Hasn't been free of controversy. Test quality and performance. What level of specificity and sensitivity is good enough, useful, informative, able to contribute to the national effort? And clearly, the way a test could be utilised potentially in terms of people boarding a Qantas flight out of London back here, compared with testing people at Broken Hill, who I don't know how many months it is since those parts of rural Australia have had a community transmission. Those situations are very, very different, of course, and having that dialogue. But our role is to look at the actual performance of those tests. Who should use them? And again, there's lots of views on that. Now, some states and territories, and I'll refer to that shortly, have decided that we were a bit Wild West, so they'd put in a bit of additional regulation. They can in law. I remember Dean writing me saying, how can most states and territories do this? Well, the Victorians decided to put their railway tracks a different distance apart from New South Wales, and we couldn't stop them. Where do rapid tests fit? And I still believe a dialogue has a fair way to go as far as the role of rapid antigen testing in particular, and especially the international border question. So this is likely to be a controversial slide. I mean, at the moment, we opened up the range of home tests, but the overwhelming view was that COVID tests in Australia shouldn't be available for home use, although it's been opened up just recently since the 1st of October to a number of other tests. Issues of interpretation. And I guess one of the things, at least in standard Australian detecting community transmission and so forth, the turnaround for PCR testing is now getting pretty quick. I've actually been PCR tested 4 times for COVID. And the most recent test, I actually got back in about 31 hours from being taken. And it wasn't, I didn't say, I just did anonymously. I didn't pull rank, call Greg Hunt to get him to speed it up. And that's a change. My very first one took almost a week, and I spent a week talking to the dog. I've been in ISO 4 times. But anyway, to cut to the chase, this is going to evolve. I don't think anything is static, and I think it is important that this group is part of that debate. I flippantly mentioned state restrictions, and again, some of you will know, we forget that, and I show the swimming costume analogy, where blue states call these things cozies, yellow states call them togs, and the green states call them bathers. And when we go to the beach as a family, my wife is from Brisbane, my adult daughter lives in Melbourne, and I'm born and brought up in Sydney. So you can imagine we pack 3 different things when we go to the beach as a family. So again, it just shows some of the challenges, and these states felt appropriate to add extra conditions. We're doing a post-market review of rapid antibody tests there. We have also done some other tests, but this one mainly focused on rapid antibody tests. Some of them didn't work very well and got cancelled, but others, again, in the windows for sort of the later period of infection, 14, 21 to 30 days, the sensitivity and specificity of quite a few of them were very good. And I do feel that, I mean, people don't expect HIV tests, serological tests to work, rapid tests to work in day one. So I think there was a lot of poorly targeted commentary on these tests initially. I mentioned that FDA had done a bit of a mea culpa, and this has been published. And look, Jeff Shuren, who I know very well, is a very straight shooter, the head of medical devices at FDA. And they actually let them in without any review at all. And now there's an awful lot of having to play catch up in the US. I think that's the simple takeout from this. Having said that, just last week, the first de novo approval for the bioMérieux test was done. I think that will encourage just look at the size of a market and also look at the size of the disease pressure there. That will really spur another cycle of innovation. So I think FDA is saying, well, we didn't quite get it right last year, but now I think they really will show a leadership role globally in that area. And I must admit, I admire the fact that they went into print saying they didn't get it right. But I don't know if we'd get off with that in the Australian situation. Variants are, of course, an issue. Everyone's focused on variants when it comes to vaccine efficacy. But of course, variants are just as important for test performance. And we're currently, and it's a massive piece of work, partly because there's so many tests, but also partly because companies have varying amounts of information. The data's still coming in. We've asked 76 companies to send us stuff, and we're working with them. Some of us obviously have sent, and companies, of course, don't want to tell us, they don't know. So it requires legal letters going back and forward sometimes to get stuff out of them. It appears, and this is early anecdotal superficial results, but it appears that most PCR tests seem to be okay because they pick up several sites, and primer binding doesn't seem to be affected. The trouble with serology is some of the companies have really struggled to get, say, enough sets of sera from Brazil or sets of sera from South Africa or wherever. And the antigen tests, again, sensitivity might be a little bit less, but they don't seem to be as effective, but we're still looking at the data. So I wouldn't want to say anything definitively. Once we get to a certain stage of at least having most of them in, and this is a dilemma, if we wait to have every result in, it'll be 5 years' time. But when we get enough, but we have confidence saying something, we'll again publish the results, and there'll be some tears and there'll be some happiness, but it is important for us. What we do now, if say a state government path lab is saying, can you tell us whether this test is okay? We answer the question in confidence. So we're not playing secret squirrel until May the 1st or whenever, but you can understand why we're not putting out a detailed statement at the moment. And we're also talking a lot to international regulators because some of them do have access to broader panels. Advertising, again, there's sadly a number of cowboys. I mentioned paint companies and building companies that decided they'd have a quick line in COVID do-it-yourself tests. A lot of breaches, advertising tests that hadn't even gone on. Gee, TJ, what's that? What do they do? Do we need to get approval to sell this thing? Obviously, unapproved restricted representations. You can't advertise curing COVID or treating COVID or even certain things. Or this test has been approved by TJ and endorsed by TJ. You can't say that. And we've also worked together with Border Force because there were some organisations bringing quite significant numbers of tests, along with other things like fake vaccines and medicines and so on. In this area of test kit advertising, we've issued 14 infringement notices. An infringement notice is a bit like a speeding ticket, a bit more expensive, huh? But at the end of the day, if a company or organisation says, no, we didn't do that, they have their right to not pay it and take it to court. They don't have a right to not pay it and do nothing because, again, like an unpaid speeding ticket, they'll come after you. But they do have a right of appeal. Just to wrap up, two things. What did we hear from industry? Well, it was hard to get, and it was very difficult for industry to validate tests when the disease had just been identified a few weeks earlier. I mean, it's hard enough for long-established tests often to long-established diseases to validate them. It was hard for production to be scaled up, and often we'd find that one product actually, they even looked different and they performed differently. There was very significant batch-to-batch variation because they might use 3 manufacturers with 3 different types of nitrocellulose in the lateral flow, those sort of things. And there was problems in getting enough components. And of course, I've talked about shipping. Some of the consumables were difficult to get. and the capacity of clinical testing labs. We work very closely, not only in survival for other sorts of tests, but in ramping up, we as a health department, putting my broader hat on, in ramping up testing. And of course, it was complicated for industry because we had one set of rules. We were one of a few who was approving these things, looking at them end to end. Other regulators had emergency use systems, other regulators had exemptions. So it was complicated with different rules in different jurisdictions. What was our reflection? We did have to balance the need for rapid access to tests, but we felt a bit like the vaccines, where we've just, this morning I was in at the Senate defending the fact that we didn't have an emergency use authorization. We wanted to do a full review. We took the view that for confidence, it was important to review those PCR tests that were going to be used so widely and review all the others. We didn't need an emergency exemption forever. Unlike the US, we don't have home tests, and we've been criticised a bit for that. And I can always talk at more length about why that policy decision exists. A number of risk mitigation strategies. I've talked about the independent assessment and conditions placed on tests. Now, the final thing is a challenge, and it may well emerge. And I guess what I'm saying, and it won't be for me to make the final ruling, these are made by public health groups, but I think we do have to have a more structured and sophisticated discussion as a nation. Neither do I. Sorry, Siri. We do have to have, that's a very good segue into my final comment. I think there's a need to have a more open and structured understanding, and it's probably not Alan Joyce screaming from the sidelines or any one individual, about the role of rapid testing. I mean, the ability to get a result in, I bragged that I got my last PCR in 27 or whatever it was hours, but the ability to get a result in 15 minutes is just changes the whole paradigm. And I've got a fan. But so I don't think we're actually at a point where it'll be the same for the future. I think this will evolve, but just how it evolves is a dialogue that many of us need to have, including the industry. Thanks very much.
Thank you, John. That was really helpful. And I just wanted to convey to you again, we had Tracy Duffy in the room earlier today. And I think universal acclaim from our members for the terrific work that you did and your team did during COVID. They were so responsive. They worked with us. So I think, that deserves a round of applause from the members here as well. Look, I will move on. Maybe we'll hold some questions till the end. Mary Louise McLaws, I know you need no introduction, but Mary Louise is going to walk us through some of the difference between what we see internationally and what we see in Australia in the fight against COVID. So, Mary Louise, we'll have your presentation up shortly, and I think that goes forward and that goes backwards, something like that. Anyway,
so I'm going to focus on how we can use rapid antigen tests to augment PCR, not to take over from PCR. That's what, so rapid antigen tests really should never be thought of instead of, given that we are a country that has fantastic pathology with good resources, except I will remind you a little later where that should be. Sorry, I'll go the other direction. Yes, thank you. So globally, rapid antigen tests, or otherwise known as RATs, for diagnostic purposes, WHO expects them to have at least an 80% sensitivity and at least a 97% sensitivity for diagnosis. I'm suggesting today that we use RATs for screening. In other words, people will be well, they won't be having any symptoms, and particularly when they have had a vaccine, I'll go through that in a moment, that is when you need to screen, not diagnose. So this is a slide just to remind you that there is at least 16% of us who live outside of residential aged care facilities that will be asymptomatic and remain asymptomatic for the whole time that you're infected. So for a group, and you need to remember that, because when I talk about the proportion of the community that may not ever get vaccinated, they may also be one of this group here that never present with signs and symptoms. So they could effectively continue to spread infection. And so could that group that are vaccinated with AstraZeneca or Pfizer who never develop an immune response. Also, if they get infection, they have a 16% chance, or at the upper limit of the 95% confidence interval, 19% chance. Of course, in aged care, it's a little higher. The other issue is that pre-symptomatically, you're infectious for about 1 to 3 days, and you're highly infectious when your viral load is high. And this gives you that lovely illustration of the fact that your viral load is high before you have symptoms. So it's a perfect test for screening, not for diagnosis. So here, the PCR shows you that it's very good. And it's a very good one for diagnosis, but your rapid antigen test is brilliant for before you hop on that plane, when you arrive in Australia, that our government has kept us so safe. We want to keep safe, and this is where you could triage people to make sure that you remain safe. And of course, the antibody test is great. And I'm suggesting that rapid antigen testing is what we need to ensure that when you've been vaccinated, you truly are protected, because you won't know. We have to start the conversation about at what level our antibodies should be to ensure that you are protected. Because I'll show you in a moment that herd immunity is a factor of the transmissibility. And I'll show you in a moment, I've put it at about 3, the vaccine efficacy and the number that we can get to be vaccinated. And there'll be about 1/3 of the community who won't be protected. And we need to know, of those that have been vaccinated, how many are unprotected. Sorry, wrong way. Okay, this is a really nice illustration for those of you who aren't lab-based. The blue shows you that your viral levels are very high, and that's where rats come in. They're very good at identifying then and there, and that's what you want, that pre-symptomatic phase before you get on the airplane, when you get off the airplane. If state governments decide to put up state borders and you have essential services needing to cross borders, or you have ring fencing communities and they need to leave, 15 minutes they can wait by the side of the road and they can leave safely. But we did see in New South Wales, sadly, 2 people were essential services and they left without testing. This just goes to show that, of course, I do wastewater testing for antibiotic use and antibiotic highly infectious pathogens. And this one, and I love wastewater testing, but this one shows you that our wastewater testing for early warning is not good at early warning, because it only starts when you start to become symptomatic, and then it stays for a long time. The same with PCR. It remains positive for a long time. So the reliability of rats, a function of your viral load. Tick, great. Therefore, very good when you're pre-symptomatic or in the first week. It does not replace PCR, it augments PCR. I'm assuming that it may not be adversely affected by mutations because they target the N protein, and mutations at the moment are targeting the S. WHO, just to remind you, wants rats for diagnosis. They've sent out over 100,000 rat tests to Sri Lanka, and over, I think it was 120 million tests around the world in low income countries that can't build up their pathology. for diagnosis. And for diagnosis, they would prefer about 90% for sensitivity and about 99% for specificity. Just to remind you, how are our group? Now, this one was done in the Lancet ID, and all of those ones meet most of the acceptable, but they all meet the desirable level of specificity. So when you're testing somebody, you want to make sure that they leave that airport and maybe go home to home quarantine. Eventually, we might start to think about that safely, or that the staff go home. Now, at the moment, they're tested for PCR, which is saliva, that's got 80% accuracy. And yet it could be augmented with a rat. Choose your rat, because, oh, just by the way, if you have a false positive, CDC has already organized this to say, a positive, you get, of course, a PCR. So if your rat is positive, you get a PCR. It never sits by itself. It should be augmented. Now, here are the ones that the TGA have approved. And I have data on 11, but if you have a look, here is what I want you to focus on, because it's not a diagnostic test. I want you to think about this as a screening test. People look well, they sound well, but they don't know that they are an invisible risk to the community. So I'm suggesting that a rat be used for screening, not diagnosis, except in one condition. And that, of course, is our remote community. So post-vaccination, screening will still need to be done. Why? So I've done this analysis, and of course, I have to give credit to the husband, who's a great grapher. So he's put that graph up for me. All the blue represent the herd immunity that we need. I've done it at the R0 of 3, and you will see that I believe that we'll move to this section here. AstraZeneca 90%, Pfizer 10%, and we will have a proportion of around 29%. Oh, sorry, 19%. Thank you. Can't read my own slide. 19% that think they're safe but aren't safe. And they will place our community at risk when they start traveling around. So that dotted line at the top represents worst case scenario of an R0 of 5. So we will always have a proportion based on the R0 and the vaccine efficacy of who will be at risk of spreading. So having a look at this, if we're looking at Pfizer, we now got 10% that will probably get Pfizer and about 90% AstraZeneca. There will be 85% will be needed to be vaccinated to get herd immunity. I believe Australians are very good at uptaking vaccines. And I think that we focus too much on vaccine hesitancy. We are not Europe. And the UK, we've probably inherited this from, many centuries ago. They are also brilliant at taking up vaccines. So, and of course, Rogers, back in post-war, developed a theory that said there'll be innovators, early adopters, and late adopters. And then there are those that will never adopt, like seatbelt wearers, you had to find them. I think we focus on those early adopters and late adopters, and then the rest will come on board. So we will have about 66% will be protected. However, 19% of those that think they're protected won't be, and another 15% who won't be vaccinated won't be protected. So we have a problem of an assumption that vaccines will look after us. So this is where I think rats come in. So just to remind you, the viral load will be reduced once we get vaccinated, but we still, and so that will impact PCR and rats as well. But the unvaccinated and the unprotected who are vaccinated, they're our real problem. So, because I think that we will find AstraZeneca will work well, even for asymptomatic. So we really do need to look after that group because many of them will be pre-symptomatic and they will remain pre-symptomatic or asymptomatic. So the vaccine passport sounds like a good idea. However, there'll be a proportion of those coming from other countries as well. And they need to be tested with a quick RAT. Of course, they have a PCR test if they're coming on Qantas 3 days before. A lot can happen in 3 days and a PCR is not perfect anyway. So they may turn up and Mr. Joyce may expect them to have another RAT at the airport before they board, one when they arrive, and of course our outgoing ones as well. Will be coming back, most of them, and they also need to be tested. So RATs do have a great place. We need to modify our quarantine eventually, and we might be able to have a triage system. You've been vaccinated. This is where we need to talk about what your antibody levels will be after you've been vaccinated to make sure you really are a seroconverter. If you're negative, you go home for quarantine. You may have another one, a take-home one, when eventually Professor Skerritt is happy with that. And if you're positive, you go to your facility and then you get tested again. Even if there is false positives, it's not a disaster because they're already having to go to quarantine and they get a PCR'd. Quarantine staff are really important to us. I actually believe that everybody that works with anybody that is a traveler should be vaccinated as well, not just the front door and the back door of the quarantine hotels, including the front and the back door of hospitals as well. But there'll be about 13 to 21% who won't be protected, and they still need testing and their result from that day after working that day before they go home to their community. And I really thank the government for adding their household for vaccination because that was a brilliant addition. So last slide, quick screening at the international borders, a RAT, particularly if most of us have been vaccinated. Quick screening for any massive gatherings if we're very concerned about any circulating virus. The fly in, fly out workers from, of course, Papua New Guinea need to be looked after, or any of the fly in, fly outs if any of the borders have been closed. Remote communities without a laboratory, this is where I think the diagnosis should happen. And that's it. Thank you very much.
I don't know if it's just me or whether everybody finds Mary Louise is just so capable of making a message so understandable, so digestible, and so easy to follow. So thank you. It was excellent. We're going to shift tack a little bit now, and we're going to look much more closely at the Australian innovation scene. And Dr. John Melky from Genetic Signatures is going to take that on. So, John, I welcome you to the stage.
Thanks so much, Dean. Thanks for the invitation today. I'm coming from a local company, but my intention is to speak to you about innovation and funding and how technology can be taken through the commercialization process. So I am from Genetic Signatures and I will be using Genetic Signatures purely as an example of the type of innovation. And I want to take you on the journey that we went on because I think it's critical in understanding how we can raise the likelihood of Australian innovations translating into a commercial success. So very briefly on Genetic Signatures, we are a listed company on the ASX. We are a revenue stage healthcare focused company, and we've developed our own proprietary technology, which we call 3Base, which is a molecular test, a PCR test, which as we heard is the gold standard. But we do things a little bit differently with our 3Base technology, and we make the organism's genetic code more similar to each other. It's very important in picking up viral variants because we actually make the variants more similar to the first sequence which was described. So doing that, we're better able to detect groups of organisms and those mutations. We are an Australian manufacturer and we sell our kits in Australia, in the US, in Europe, and in Africa. So you can see on your right that we do have an extensive range of tests available, and they do include SARS-CoV-2, the virus that causes COVID-19. So we have had a somewhat busy 12 months. If you will indulge me just for 1 minute, no more, I'll take you through our technology, because really, one, we're exceptionally proud of it, but two, it's a really good example of Australian innovation from discovery right through to commercialization. The technology itself is quite advanced, and as I said, we changed the genetic sequence. So we actually change, if you know of DNA and RNA, it's a 4-letter alphabet, and we actually changed that into a 3-letter alphabet. So we changed the C letter into a T letter. It's very similar to a 10-digit number that might have 4 variables at each digit, compared to a 10-digit number that has 3 variables at each digit. And all this on the right-hand side is showing you that really corresponds to 1 million variants being reduced down to about 60,000 variants. So it's a very effective way of bringing groups of organisms together. So that was my minute. Thank you. It does work. It does work in the clinic, so we were able to prove that early. This is an example of using gastroenteritis. It was a study we did with St. Vincent's. But what you can see is that our 3-base technology was able to detect almost twice the number of infections as their standard of care at that time. But importantly, at the start of 2020, we were able to quickly pivot and apply our 3-base technology to develop a SARS-CoV-2 assay, which was quickly approved by the TGA, which we thank you, and also CE-IVD marking. And that was done in April of 20. So this is really just a timeline of how we were able to move quickly. But the key to supporting that rapid development and the regulatory approval, I think, was the successful capital raise that we did in November of 2019. In hindsight, it was perfect timing. I do often reflect what we would have been able to achieve as a company if we did not have access to that capital. Especially in January of 20, there was a lot of uncertainty. There were many companies that didn't dedicate the resources in developing a test in case it was very similar to the original SARS and if it would go away. Resources are scarce. So we were in a very fortunate position. There were at that time no government programs to develop a locally made solution, nor to scale up production. And it was in a time when we've heard there were so many supply constraints, global supply constraints. So I do often wonder what Australia's control of the virus would have been like if we didn't have access to the offshore suppliers. There was talk of a hard border close at some point. Fortunately, it didn't happen. Now to talk about our innovation and the company and the journey we were. So I really just wanted to comment on our journey. And the important part is it was a 20-year journey. It's our 20th anniversary this year. Of most importance is how we were financed. We were co-founded by Mr. Christopher Abbott, who's here today, who put in some 17 million almost of his own family company money, which allowed us to develop this unique Australian technology. We had to diversify our funding sources and list it on the ASX during that process. But the key point really is that a commercial success today is often based on a discovery 10 plus years ago, sometimes even 20 years ago. I do also wonder what would happen if we were founded today and not 20 years ago, and what's available to Australian company and Australian innovation. So I'll spend the rest of my time now just looking at the type of programs that we have available. We know that Australian government support for business is mainly indirect, and that's what this graph is showing you. This is looking at OECD companies and the percentage of funding that's direct, as in grants, compared to the indirect, which is really through taxation benefits that companies can claim. So Australia really does stand out on its reliance on tax incentives, or the indirect types of programs that allow companies to claim back some of that cost of their R&D. They can encourage innovation and do, and we've certainly benefited from that, but they do benefit larger firms, or they benefit firms that have the funds and the means to develop the R&D before being able to claim some of it back. So certainly missing from our current program is direct R&D funding at a meaningful level. So 88% was indirect. So there was research based in the US, a small business innovation research, which really showed quite nicely that that direct grants allow firms to prove the viability of their technology. And what they found is it led to extra funding through VCs and risk capital, because the grants themselves were a way that they could sort of take some comfort that the technology has already been through a competitive process with expert referees. This I find really interesting, and the slide it's a really telling comparison on the number of Australian startups per $100 million in research expenditure. You can see Australia's at the bottom there in the red. It really does lag behind the rest of the world. So dedicated funding for companies like ours would allow more of that translation from the R&D into a product and into commercialization. We certainly know that CSIRO has a current strategic focus as Australia's innovation catalyst, and there has been a significant shift in emphasis to that endpoint. But in terms of building sovereign capability, or in terms of how we can foster our domestic innovation, it really comes down to 5 areas working together. Of course, there's the R&D, there's the government, there's industry, there's education, and importantly, it's the culture that drives that. I mentioned this morning BARDA in the US, which is a government-funded R&D organization, and they're designed to invest in research to ensure effectively the safety of the US. They've invested in a number of Australian companies, including Loom in Queensland, giving them a grant of over $200 million US, procuring some of their products and also setting up manufacturing in the US. One thing we could consider, somebody in the room just earlier today was saying, you know, a lot of university research never makes it out of the university. And it has been suggested that perhaps a 20% collaboration premium to an R&D grant would be effective in joining companies, private companies, to the world-class researchers that we have all over the country. And it's a really simple measure, but would allow the top researchers in the world to work more collaboratively and really build and lift the level of innovation in Australia. We heard this morning too that there was a suggestion that even 2% of the country's superannuation could be used or redirected into a BARDA type fund, which is really there designed to nurture R&D all the way through to commercialization. So I might just conclude by saying that certainly the pandemic has given us an example of why local infrastructure is so important, because it certainly revealed the potential vulnerabilities, and we have been through them today. Government can certainly help by driving domestic growth and possibly a preference for local supply, as well as importing solutions as required. But importantly, the government, as we've seen today, has access to Pathology Technology Australia, who are here willing and able to interact, help, and come up with ideas, really with the one goal of lifting Australian innovation.
Thank you very much, John. Maybe if I could ask the 3 speakers to maybe stand and see if there's any questions from the group. Any questions for John, Mary Louise, or John? Mark?
Questions to John. John, you mentioned earlier you talked about there's a lot of companies that technology response to the outbreak. Is there an opportunity there that certain companies, certain organisations before TGA would hold them in well, that question's been asked numerous times. For example, complementary medicine in Australia, they struggle with a lot of fringe wells,
is remarkable. We have, in law, there's no ability for us to require membership in associations. In law, any individual or organisation can apply to become a sponsor of a product. And that's what we saw with paint companies and building companies, and I could go on. There's a lot of weird and wonderful groups that thought they could make a quick buck out of COVID tests. It would make our life a lot easier. The downside of that is constitutionally and legally and in administrative law, there are a few challenges in requiring someone to be a member of a particular organisation. So our public and private view is we always say to people, yes, it costs you a few bucks, but you get a lot out of being part of an industry association, apart from the main thing being a fair bit of free advice about what you can do and what you can't do, and also learning from your peers, both about commercial development as well as the regulatory system. It's not all about regulation. But generally, our political masters of both colours have been reluctant to require companies to be a member of an organisation. And I'm sure that the administrative lawyers that have a picnic about that, it would probably be seen. I don't think it's unconstitutional. It would probably be seen as inappropriate in administrative law.
Thank you, John. And Troy.
Is it feasible for the TGA to do any collaboration with some of these institutions in the UK, such as Port and Dow or Guy's St Thomas Hospitals, Imperial, King's College, and the like, for some raw data when we're validating saliva tests?
Well, again, I'll just yell. It's okay. Unless you're recording this, so I'll talk to this, right? I better talk to this thing. We will work with any organisation on data, and quite often sponsors will provide data from a reputable organisation such as those. But the onus is really on the Australian. So let's say Australian sponsor X wants to adapt their test for saliva, and a top shelf British research organisation has gathered a lot of data. By all means, come to us with that data with the research organisation and so forth. But really, the sponsor has to be the middleman or woman in that relationship. I mean, we do talk to these international organisations all the time, but once it comes down to a particular product and validation, that's where the company is important to be part of the discussion.
Any other questions, comments? No? Oh, Ali.
Thank you. It's for John again. John, you're getting hammered with the questions. Thank you for your presentation. And one of the things you said you can ask me about that later, so I'm going to take the opportunity to ask you, was about home testing. And you said home testing is a no. In the panel discussion, this for COVID. I thought it was for COVID.
Okay, so there was until quick history lesson. From October 1st, 2010, so 11 years ago, 10 and a half years ago, home testing was, apart from things like monitoring INR and so forth, home testing wasn't on. Then became a certain number of things that were allowed for condition monitoring. We then had there's a rule where bits of regulation will sunset after 10 years, and that's good practice to make sure it's contemporary. It keeps our lawyers and drafters busy. So when we saw 2 years out that this was going to sunset, I should just add HIV was dropped in self-testing in 2015. Well, 2015, the first products took a couple of years to get to market. I remember actually doing it with Minister Dutton, which was 2015. Hunter's been minister since January, February 2017. But you're right, it was a couple of years till companies, Atomo and others, came onto the market. So so we did a consultation, and there was a wide range of views about. Yeah, you put one in, and as did a number of members, and as did a lot of the medical fraternity, and even they were very divided. But it fell that certain things like genetic tests, people were very uncomfortable with. Tests for oncology diagnoses, people were very uncomfortable with. You don't want to get one of them at 3 a.m. when you're by yourself. However, influenza, a number of sexually transmitted diseases, and so on, and greater emphasis on monitoring of conditions and some other respiratory pathogens. COVID was felt in the Australian context. Again, there's always interaction also with it being notifiable. And one of the really important things was the importance of knowing where COVID are. My colleagues from overseas, I'm on the phone tonight again with FDA and EMA, they'll talk about where the latest 10,000 cases were. We get on the front of the paper when you have one community case, and thank God it is like that. It's so, in Queanbeyan, we find one community transmission of COVID, front page news. The worry, there was several concerns about it. The concern was that those results would not be made public, that there would be the risk of people saying, oh my God, but I need to go to work because I've got to support my family. And you can understand all the personal drivers for just saying, look, I've got a bit of an allergy today. I'm sneezing because of all the dust. Because, COVID can, especially in mild forms, or even asymptomatic, as Mary Louise explained so eloquently. So for a number of reasons, that was one of them, but there's about 7 other reasons, it was felt when we went to government, because the minister is the one who advises on these things. I made the instrument, but it was obviously with Minister Hunt's blessing and showing what the group thought. We felt that home COVID tests in Australia. Now, had we been New York City, again, with different pressures, maybe a different outcome would have come.
Thank you very much, John. There's an online question. I'll get away from the speaker. There's an online question. Mary Louise, what are your thoughts as to why the state, well, this is loaded, why the state public health authorities only favour PCR testing and do not recommend or endorse rapid antigen testing based on your world experience and clinical validation? What do you think?
Yeah. Well, that's explosive. One can assume that there's a misunderstanding about the difference between diagnostic tests and screening tests. So when people are called out to come and get tested when we have outbreaks, and the Australian community has been amazingly wonderful getting testing, all of them are either pre-symptomatic or asymptomatic. And so some of them may be diagnostic, but a lot of them are screening. So they could have had there been the will to actually include rapid antigen testing for screening. There would have been many that would be false positives, which is terrific, better than false negatives, and they could have had PCR. So I would like to see the world change now that people are starting to get used to rapid antigen testing. I mean, we are an innovative country, but we're also cautionary. And so now is the time, because we are in a very safe place. And when 85%, 90% of us get vaccinated, we will still need some screening and some diagnostics. So there'll be 2 separate ones. So for Dominic, I think it was, all I can do is leave it hanging in the air that there has been some monopoly on one approach, rather than thinking that sometimes there is screening as well. So now is the time to start getting much more proactive about using both according to the appropriate use.
That's absolutely right. All righty. Look, I think we will leave it there. It's been a long day for many of us. It leaves me to, first of all, thank the Minister in his absence for opening. I know that the Minister, as you know, has not been well, and he forsook all his other activities today to be able to come to this opening. So I think that's a pretty good mark. I think that he's listening, he's aware of us now, which is terrific. And the fact that he prioritized us against anything else that he had on today, I think was a mark of respect for us, which I really appreciate deeply. Our speakers today, the 2 professors and Dr. John, we really appreciate your insights. And to everybody who took the time to come to Canberra today for this Innovation Day, I hope you've been able to network, meet people that you've not met before, get something out of it. We'll take all of what we've learned today away and think about how we can make one of these days even better in the future. So thank you all so much, and farewell.